So sorry about our technical delay this morning. 12 months into the pandemic, you would think that we would be proficient with Zoom, but sadly, I cannot say that that is the case. Again, welcome everyone to our WDX VMR this morning. We're so excited to see you all. We have a great case, and before we kick off, I just wanted to do a quick reflection, and then we'll go around and do some introductions before we get started. Just to kick us off, my name is Smitha. I'm one of the second year residents at UCSF and one of the CP Solvers team members. Have been really excited to be involved with WDX over the last few months as well. Wow, it's so fun to see everyone in the chat. This is awesome. Just to kick off with a quick reflection, just a reminder that the VMR space, the virtual morning report space, is a safe space where we come together and discuss a clinical unknown case together. And in particular, the WDX space is special to me and to us because it's a particularly safe space where we center and celebrate women in medicine and underrepresented voices in medicine. And so we're really excited to have another one of our monthly spaces here today. And I think we've talked a little bit about this space before, but I was kind of reflecting on why this space has been special for me. And I think there are sort of three design elements that have been really important to me. And the first is that we do select a case presenter and discussants in advance. And that's because we know that women and sort of other underrepresented voices in medicine tend to struggle with, just like everybody does, this voice in the back of their head that's kind of holding you back. And so sometimes when we're asking for volunteers, those folks may not be the first to feel comfortable raising their hand to enter into the lukewarm seat. And so if you're at all interested in learning more about being involved with this VMR community, WDX, want to discuss a case, please do reach out to us. And then the second is that by design, we say, I don't know a lot. And to me, that's really important in part because I think it's easy for, people who know a lot like Prez, Charmine, or Reza, or Ravi, maybe easier or hits different when they say, I don't know, than it does when I say, I don't know. And so hopefully watching us, kind of be authentic to ourselves, our knowledge gaps, and saying, I don't know a lot will encourage some of you all to come join us as well. And then the third design element is really just that we're here every month. We put ourselves out there. We are committed to this process. And so we're looking forward to learning with all of you. With that, I will pause and let the rest of our all-star team introduce themselves. And I will popcorn over to Anna.
Good morning, everyone. Happy Monday. Really excited for another WDX VMR. Thanks for sharing that reflection, Smitha. It is such an honor to be able to discuss with you today. She's my OG in WDX from day one of residency. So I'm a second year in also internal medicine with Smith out here in San Francisco. And we're joined by some other great folks today. So I'm going to popcorn over to Jordan, who is our case presenter today.
Hi, everyone. I'm Jordan. I'm a first-year internal medicine resident at UCSF. Very, very grateful to be here to present a case with all these amazing women and all of you people that are here with us. So I hope you enjoy the case. I will popcorn over to Priyanka.
Hello, everyone. I'm Priyanka. I'm a fourth-year medical student here at UCSF and CP Solvers team member, and I'll be scribing the case today. And I'm super excited to learn from you all and get to be a part of this amazing community. So thank you, Smith and Anna, for taking us through this process today. I will popcorn to Sarah.
Hey everyone, good morning. My name is Sarah Honorato. I'm a fourth year graduating medical student, which is weird to say, at Harvard. I'll be at Brigham and Women's Hospital in a couple of months for internal medicine residency. Very excited to be joining today and looking forward to the case. I'll popcorn over to Ashwini.
Hi, everyone. Good morning. My name is Ashwini. I'm also a fourth-year medical student here at Harvard, and I'm going to be doing anesthesiology in a couple months at MGH. I think, is that it for our team? I'm new, so thank you so much for having me on this episode.
We do have Sukriti, who is, I think, doing our teaching points today. And so let's have Sukriti introduce herself. And then maybe you all can take over the screen and we can get started with the case.
Hi everyone, I'm Sukriti and I'm doing teaching points today. Super excited for today's VMR.
Amazing. All right. Let's see, Smitha and Sarah, do you all want to partner up and tackle the first aliquot? And Jordan, would you mind telling us how many aliquots are in today's case?
There are 5 aliquots.
Okay, 5, and then final DX or 5?
The final DX is aliquot 5.
Perfect. Okay, so Smitha and Sarah, maybe y'all can take 1 and 3. And then Ashwini and I will take 2 and 4. Cool. We're excited and nervous.
You'll be great. All right, are we ready? So this is a 45-year-old man sent in by his primary care doctor for expedited workup of chronic iron deficiency anemia. So 3 years ago, the patient was noted to have iron deficiency anemia. Per the patient, he's taken long rounds of PO iron and had 2 IV iron infusions. However, his hemoglobin has remained low despite these therapies. Upon further questioning, he tells you that about 2 weeks ago, he developed an episode of constipation, and ever since then, he has been having daily fevers up to 101 measured at home. Over the past 2 weeks, he says he's lost about 15 to 20 pounds. However, he's been eating much healthier, cutting out carbs, and he recently started metformin. Also, for the past 2 weeks, he's been waking up in the middle of the night, drenched in sweat, having to change his sheets. He's noticed some intermittent right upper quadrant epigastric pain that's been sharp and pulsating, and that's not associated with food or other clear triggers. On review of systems, he denies runny nose, sore throat, chest pain, shortness of breath, dysuria, any fatigue or dizziness. He's had no recent travel, no exposure to animals. He doesn't have any pets, including any birds, and he's had no recent insect or tick bites that he can remember. And that's the end of aliquot 1.
Amazing. Sarah, what a rich aliquot that we just got here. I'm curious what parts of the HPI are standing out to you as potentially signal.
Yeah, Jordan, thanks. That was a lot of information to contend with in the first part here. I think a couple of things stood out. So it sounds like this is a middle-aged guy, and he has sort of a chronic history of anemia, and then this more acute or to subacute 2-week history of constipations and some sort of inflammatory syndrome going on. I think we can pretty confidently say that with the fevers, the weight loss, the night sweats, that cues me in that there's some sort of inflammation going on in this guy. What I'm trying to figure out is whether that's related or unrelated to this chronic history of iron deficiency anemia. And then he also has this right upper quadrant epigastric pain, which again, may be related and maybe sort of something that we can hone in on as the source of inflammation in him, but not totally sure what to make of that at this point. In terms of the iron deficiency anemia, I think that's one thing that in medical school, we learn a pretty good framework for thinking about anemia. And so I'll be curious whether this is a blood loss anemia and he's been losing blood chronically and that's why he's iron deficient. If he has some reason that he's not absorbing iron well. And I'll also note that in, a woman, I might think about that a little bit differently, but this is a guy, sort of young guy. And so that makes me pause a little bit and wonder what his reason is for having iron deficiency anemia. And then the other thing that stood out to me in the history was that he just started metformin. You know, diabetes is pretty common, but 45 is a little bit young to be starting metformin. So is this a new onset diabetes? And is that going to be some sort of signal to what's going on in this guy? Or is that just noise and sort of base rate that he's, you know, maybe a little bit overweight or obese and that's why he's developed diabetes? So maybe I'll pause there and pass it to Smith up to hear some of your thoughts too.
Absolutely. I love that. And I love the internal medicine approach of sort of like tracking all of these different problems and then thinking about, could they be related? If so, how? But also making sure that we're thinking about them separately. And the threads that I heard you pick up on were the iron deficiency anemia is something that's odd, specifically, you know, its refractoriness to therapy. And then the second thing was the inflammatory syndrome, with fever being the most specific, but certainly weight loss and night sweats also kind of falling into that cluster. And then the third thing being the abdominal pain, and how could these different things be related? You know, I think chronic anemia is something, it's interesting and not something that we see necessarily in the inpatient setting as frequently. When I think about chronic anemia, well, usually I use anemia times the time course to think about sort of what's going on. So in the acute setting, usually I think about things like blood loss or hemolysis. And then in the more chronic setting, I usually think about a production problem. And that could be because either the environment, so things like we are lacking the raw materials, things like iron, heme, you know, other sort of raw materials, whether there's a toxic type picture, so things like alcohol can be toxic to the bone marrow. Certain medications can suppress the bone marrow such that we can't make as much hemoglobin. But then you can also have chronic loss, as you picked up on. So a slow GI bleed over time, you know, either from colorectal cancer or an ulcer or something else can lead to iron deficiency. And so I often, when I hear about iron deficiency, just like you mentioned, it brings up a lot more questions than it does answers, because it's a clinical syndrome, but we still have to explain why. And then that sort of answer to why, I think, just as you pointed out, probably lives in this sort of inflammatory syndrome that's going on. It could be that this is sort of in the background and now it's kind of tipped over into some sort of acute presentation. And this background is also going to be explained by what's going on in the foreground. But you also sort of explained another pathway, which is that maybe this is just happening in the background, and what's happening now in the last 2 weeks is unrelated, or the background has predisposed him to this acute onset clinical syndrome. In terms of the inflammatory syndrome, it's hard to know how to make progress on that. We're getting some signal that there's maybe something going on in the abdomen, in the right upper quadrant, and in the epigastric region. You know, sometimes when people are feeling unwell, they have abdominal pain, and it's hard to know sort of what to do with that. So we'll see if that's signal or if that's noise. But I love how you picked up on all of the things that we're going to be tracking over time. And then we'll see if, you know, this inflammatory syndrome ends us in, you know, esoteria land, or, you know, more common things being common, like something in the gallbladder pathology, or some sort of malignancy that's sort of showing itself now. I will pause there.
What a rich start to the case. So I will go on to aliquot 2 and give you a little bit of past medical history. So the patient was diagnosed with HIV 15 years ago. That's been well controlled. Last viral load about a month ago was undetectable. He has a history of latent TB, treated 10 years ago with full therapy. History of prediabetes, prior history of syphilis and this iron deficiency anemia. He had an EGD and colonoscopy 2 years prior, which was had 3 sessile polyps and gastropathy. He's had no past surgeries. His meds, he's taking metformin and HIV medications. His social history, he lives alone. He works at the airport handling baggage. He does not smoke. He drinks socially. In his family history, his mother had breast cancer in her 60s. And then I'll give you the vitals and exam as well. His temperature was 101.7. heart rate of 117, blood pressure 139/91, respiratory rate 18, O2 sat 98% on room air. His exam, he's a generally well-appearing obese man in no acute distress. HENT, he had no appreciable cervical, axillary, or mandibular lymphadenopathy. His lungs were clear to auscultation bilaterally. His cardiovascular, he was tachycardic, but regular with no murmurs, rubs, or gallops. His abdomen was non-distended, soft, but diffusely tender to palpation, worse in the right upper quadrant and epigastric area without rebound or guarding. And he had no lower extremity edema. And he was ANO ×3 without focal deficits.
It gets more and more interesting. All right, Ashwini, I'll turn it over to you. How does some of this background information inform what we learned about the patient's current syndrome?
Yeah, this is. I'll just start by saying this is a super interesting case. I think the past medical history helps us a lot in that already, another thing that was at least going through my mind was, is this some sort of like chronic infection? And I wanted to know, where he was from and like a lot more about the social history as well. So I'm happy we got that. Some of the things in his past medical history, the history of HIV, the history of latent TB, definitely stand out to me as like, we need to keep our infectious differential pretty broad. The fact that he has had polyps and gastropathy previously also make me wonder, like, is there something going on in his GI system? He's also been on medication for HIV, so could part of this at least be like a medication side effect? Those are all some things that are going through my mind. Given that he has had latent TB, I also want to know where he's from. If he's from somewhere where, like tropical diseases, parasites are also common. Could he have something like that that's been undiagnosed? And then in terms of the social history, he works at the airport. That brings its own exposures. I also want to know a little bit more about like what sort of housing situation does he live in? Is it an old house? Is there lead? Things like that. So I think in terms of what we learned about the history, it actually kind of broadens my differential rather than, helping me pin down one of any of the things that we already talked about. And then in terms of his exam, he's febrile, which we kind of expected. So he's tachycardic, which could just be due to the fever, but could also indicate that there's something else going on. I'm a little bit reassured that he doesn't have lymphadenopathy, but I don't want to take malignancy or a hematologic malignancy off my differential just yet. And then in terms of the abdominal exam, the fact that he is kind of diffusely tender with findings in that right upper quadrant region make me think like there's probably something going on in the abdomen rather than just this kind of general feeling of being unwell that's driving his abdominal pain. So what we just learned basically just brings up a lot more questions for me, and I'll kind of stop there.
That was so outstanding, Ashwini. I have very, very little to add on top of that discussion. The things that I am similarly most interested in are his past medical history, and I agree that like him having HIV, even though he's well controlled, really like broadens our spotlight for what we're thinking about in terms of causes. And we know that HIV, not only even with it being well controlled, increases risks of infection, then there's also considerable increased risk of certain malignancies. And I don't know all of those malignancies, to be honest. I don't know if solid organ malignancy is more common in patients who have HIV but certainly things like lymphomas. And I would be, I'm glad he also doesn't have any lymphadenopathy, but that would be something I would be thinking of. In the infectious, or I guess, let me take a step back in terms of just like thinking about like the site of pathology. I agree with you that like we have an inflamed patient, it's supported by his history, we see it on exam, and then we now have something potentially focal in the abdomen. So I think in terms of like money and workup, I'm really interested in imaging his abdomen to get a better sense of what could be going on there. And I would probably, even though the like presence of iron deficiency anemia makes me think that it's something luminal, I also wonder with some of the tenderness he's having, if there's like something abutting the peritoneum that would also just make like CT scanning his abdomen a helpful diagnostic step as well. And then when I'm thinking specifically about iron deficiency anemia, we already heard from Smith and Sarah this beautiful framework for thinking about like, well, what is like actually pathophysiologically happening? And like the source that I am like honing in on the GI tract, I think the maximum site of iron absorption is in the duodenum. And so I'd be particularly interested, especially with this like right upper quadrant, if there's like something happening like in the duodenum hepatobiliary area. What that pathology is, I don't know. But the things that I wanted to comment on, so for patients with HIV, the types of malignancies that I think about are things like lymphoma. I also think about Kaposi's sarcoma, although he's very well controlled, so I think that would be less likely, but certainly could present as GI bleeding. And then I'd just be like going to Google and seeing if there's like certain solid organ malignancies or something overrepresented. In the bucket of infection, I agree with you. There's like a whole bunch of things on the table, things that localize to that area in particular, like specific to patients with HIV, I'm not sure. The thing that I'm interested in with his history of latent TB, I recently learned, I kind of always thought that like once you were treated for latent TB, that was definitive treatment, but it's actually only 60% effective. And so perhaps there's some type of acute insult that we're getting from this like inflammatory background that could represent some type of reactivation. And the GI tract is the third most common site for extrapulmonary TB. And so I think that that's something that definitely still could be on the table, although much, much less likely. And then let's see, those are the main things that I wanted to highlight. I agree with you entirely. I'm interested to see what his basic labs are. And then I think I'd have pretty low threshold to start with scanning him. And then I do think I'd want repeat luminal imaging as well if his scan were to be pretty unremarkable. Any other thoughts, things that came up for you before we turn it back to Jordan? All righty, Jordan, tell us more.
On to the next aliquot. We'll give you some data. So his BMP was all unremarkable and normal. His LFTs, his total bilirubin was 0.5. AST, ALT was 17 and 38, which were both normal. And his ALK phos was 95, which was also normal. His CBC showed a white blood cell count of 12.8, which was high, which was neutrophil predominant. A hemoglobin of 10, which was low, and a platelet count of 456, which was high. His MCV was 76. He had a basic anemia workup, which showed a B12 of 540, which was normal, folic acid of 15, also normal, an iron of 17, a ferritin of 135, a transferrin sat of 5, and a transferrin of 230. His reticulocyte absolute count was 68, which was normal for the assay. And his smear showed hypochromia and microcytosis. He had a lactate, which was 1, and a lipase of 14, which is normal. I forgot to mention his total protein was 8.8, which is high. and albumin at 3.7. His first pass imaging, his chest x-ray showed clear lungs. His EKG was sinus tachycardia. And he had an abdominal ultrasound, which showed a normal gallbladder, no cholelithiasis or cholecystitis, a liver with fatty infiltration, and splenomegaly.
So Krithi, do you need anything clarified? Okay.
Can you repeat?
Oh,
Yeah, can you repeat the reticulocyte absolute count?
It was 68, which is normal for the assay.
Thank you.
Great. Sarah, lots of data coming our way, and Anna and Ashwini so beautifully layered on the background onto this clinical presentation. How is this data kind of changing how you're thinking about the case?
Yeah, so a lot of great information from Jordan, so thank you. I think I'm just going to go through systematically here just to make sure that we talk about everything, even though my eyes jumped to certain parts of the data, and also just reflect, I guess, on some things I was surprised about, which is that this is a pretty sick looking guy. And so some of these normal labs are a little bit surprising to me. So normal BMP, LFTs, especially in the setting of his right upper quadrant pain that are normal, weren't necessarily what I was expecting. We have evidence of neutrophil predominant leukocytosis, which I think is not all that surprising given that we thought he was inflamed. And so again, really doesn't help us narrow in on anything, but just kind of corroborates what we had already been thinking and what Ashwini and Anna were discussing. We also have his hemoglobin being 10, which again, we know he has the history. I'd be curious to look back and see where he sort of lived, and is this around where he usually is, or is this a little bit different than where he's been over the last 3 years? And again, he also has elevated platelets, which again might just clue us into some sort of inflammation. So not all that surprising there. In terms of I guess one other thing that was notable was the total protein that we got at the end. I guess just talking about that a little bit with an albumin being low. So we have a gamma gap, I believe, because the difference between those is greater than 4. He does have HIV, which I think can sometimes explain it, although I'm actually not sure whether in someone with controlled HIV, whether you'd expect to see a gamma gap or not. And so I'm curious whether this is, polyclonal or what might be going on here, but that kind of brings up its own differential of things that could be happening. And then in terms of the iron studies, so B12 folate normal, which is not all that surprising because he has a microcytosis, so more commonly we'd see those in macrocytic anemias. I might need some help with the real-time interpretation of some of these iron studies. Iron of 17, I think, is low. And then his transferrin saturation is also 5, which I think is quite low as well. And his ferritin of 135, I think is low too, but I might need some help on where that sits in sort of the normal range. And then his reticulocytes being normal, again, he's anemic, so whether that's normal but inappropriately normal is on the table, and I think that's probably where we fall here. So it still could be signal to some sort of production issue. And the hypochromia on the smear, I think, is pretty expected in setting of iron deficiency. And then I guess the last piece to comment on that we kind of got at the end was this splenomegaly, which again might be diagnostically helpful for us in thinking about whether he has any reasons to have portal hypertension, in terms of more esoteric causes of portal hypertension, including the common sort of cirrhosis that we think about, things like schistosomiasis or other kind of more atypical infections that can actually lead to portal hypertension, or whether there's some sort of cells infiltrating the spleen, red blood cells, and he's hemolyzing, which we don't have a lot of signal for, though he has this chronic anemia. So that might be kind of a diagnostically fruitful path to go down as well. I will pause there.
Dude, Sarah, that was incredible. Like, what a masterful discussion. And I love the way you went systematically through literally every lab, including interpreting iron studies in real time on VMR, which is truly like just next level. So thank you for all of that teaching. And I mean, I have very little to add. I will just like pick up on some of the threads that you picked up on. Just to sort of like circle back quickly to the iron deficiency anemia discussion, I often feel like particularly in a chronically inflamed patient, that these studies can be really hard to interpret. And so we typically think about, just as you said, ferritin being the best test for iron deficiency anemia. And I vaguely remember learning, it's hard to remember all of the likelihood ratios, but ferritin is the first sign of iron deficiency anemia that often will appear. And less than 15 has a likelihood ratio of like greater than 50. So if you see a ferritin less than 15, like that is slam dunk iron deficiency anemia. In the middle, the likelihood ratio is not so good, like 15 to 30. And then greater than 100 is technically not really consistent with iron deficiency anemia, but in someone who is chronically inflamed, you can actually sequester the iron. And so you'll have ferritin be elevated just as an inflammatory marker. And so often in that case, the ferritin is not that helpful. So just as you mentioned, we then look at the transferrin saturation as sort of my next best test to look for iron deficiency anemia. And so typically a TSAT in the like 5 to 10 range has a likelihood ratio, I don't know the exact number, but it's like 2 to 3. And so it's definitely not as good as that ferritin of less than 15, but it's pretty good at suggesting iron deficiency anemia. And so the fact that the TSAT is 5 is very low in this case. And so I do think is consistent with iron deficiency anemia. And then the other tests, as you mentioned, can vary quite a bit and are often not as helpful. And so we do see here, consistency with iron deficiency anemia. The platelet count being elevated is interesting. It again supports this hypothesis of chronic inflammation, either from an infection, from a malignancy, from something autoimmune. I think in this case, we're sort of leaning towards something maybe infectious or malignant. And then I want to touch on, you sort of like named what for me, I think is becoming the center of gravity in this case, which is the splenomegaly. Like whatever is going on in this case is going to explain probably the splenomegaly in this case. And so when I think about splenomegaly, I think about, well, like, why is the spleen big? Is it because, like, common things being common, just like you mentioned, there's portal hypertension, and so the spleen is big because it's congested and full of water? Maybe. In this case, LFTs being normal, no sort of volume overload on exam, maybe makes that a little bit less likely. And then thinking about like, well, what else can like junk up the spleen? Like things like RBCs can fill up the spleen. So in infections like malaria, you can get splenomegaly. Are there white blood cells that are sort of like chock full in the spleen? I think, the fact that we're seeing leukocytosis, like maybe, and getting this sort of syndrome of B symptoms, like maybe there's white blood cells that the spleen is full of. And so that has its own differential, including things like infection, like EBV, CMV, particularly in someone who is HIV positive. Tick-borne illnesses can do that, granulomatous diseases. Anna so expertly mentioned that we should still be considering TB despite the treatment for latent TB. And then with an inflamed patient who has like chronic anemia, thinking about with this protein gap, like could this be something like a myeloproliferative disorder that we're seeing splenomegaly as a signature of? And then other things like lymphoma can also lead to this. Sarcoid, I think sometimes can also present in the spleen, I think a little bit, probably less likely in this case, given that we're not seeing sort of other systemic signature. And so I really think that you kind of like hit the nail on the head, which is like, what is going on with this splenomegaly? And I'm curious, what do you think we should do next? Like if you were taking care of this patient, like is there other data that we're missing here that you would want to know about?
I think the next thing that I'd be curious about is more abdominal imaging. Now that we have some signal that something's going on in the spleen and the abdomen, is there anything else that we can see, like maybe lymph nodes elsewhere in the abdomen that might clue us into some other process? And then I think ultimately whether there might be somewhere that's suitable to biopsy if that's kind of the route we're going down.
I love that. And this idea that like, with our labs, it's really hard to localize where in the abdomen this process is. We're getting some signal that it's there, and we need to like send them to what Anna and I frequently like to call the tube of truth, which is just like the CT scan to figure out sort of what's going on, just like you said. And then you actually mentioned another thing around like getting a sense of, is this protein gap polyclonal or monoclonal? So in HIV, you can get the polyclonal gap, although to your point, like I don't know in someone who's well controlled what that would look like. And certainly in someone with an infection, you can also get a polyclonal increase in the and a protein gap. So would be curious to see what that looks like. And, it's sort of right on the, I'm really bad at math, but it's sort of like on the border. So it's not so elevated, but it's definitely not normal. But I agree with you, tube of truth. Anna, Ashwini, anything else to add?
No, I think this is really just like a brilliant discussion of the labs. I think also with this gamma gap, I would consider doing like an SPEP and a UPEP just to kind of get a sense of what is, what's going on there, because it's, like you mentioned, it's definitely not normal, and there's enough kind of distinct and kind of weird things going on in this case that I'd want to investigate that further.
Love that, Ashwini. All right, we will turn it to you, Jordan. This is just such a good
rich, such a rich discussion, you guys. So wonderful to hear all of your thoughts. So he went into the tube of truth, and the CT scan showed an irregular, enhancing nodular mural thickening and partially exophytic mass arising from the distal small bowel, likely mid-distal ileum, with adjacent prominent enlarged mesenteric lymph nodes, including a dominant mass measuring up to 4.5 centimeters. He also was noted to have poor enhancement of a branch of the superior mesenteric vein in vicinity of the mass, concerning for a thrombus. And that's the end of the saloclot.
Oof. Do you mind clarifying? Was this a luminal? Did they comment on whether it was luminal or was it like within the peritoneum?
It was, they couldn't tell if it was luminal or not.
Okay. All right. Super, super interesting. Ashwini, this is some nuanced information that I feel like I will have very little to discuss, but I'm so interested to hear what thoughts you have and maybe the next steps you'd be interested in.
Yeah, definitely. So I'll say that, these like irregular enhancing exophytic masses in the distal ileum isn't necessarily something that I have a well-formed differential for. I think as we were talking about, infection and malignancy continues to be, the two kind of big buckets that I'm thinking about for all the reasons that we already discussed. I think in terms of malignancy, you given the like lymphadenopathy, you could still think about like a lymphoma and like an atypical kind of location. You could also think about like a neuroendocrine tumor, as well as just like other more unusual things. I do think that ultimately it would be helpful to have tissue, depending on where the mass is and how easy it is to get to it, either from there or from like one of the lymph nodes, could be useful. I think also, this could represent focus of infection, the things that we talked about before, like TB, other infections. The thrombus makes me, or the concern for thrombus, I guess, makes me lean more towards malignancy, given that would lead to this kind of hypercoagulable state. So I think ultimately we need tissue. I'm not sure like what the right approach to get that tissue would be, but I would definitely involve my procedural colleagues at that time. So I'll leave it at that. And super, super interesting learning case.
Absolutely. Ashwini, first of all, I love that you in the last aliquot thinking too about the patient's like protein gap. I thought that that was like a brilliant add-on, and I agree with you. I would definitely be wanting to send like SPEP, UPEP, and immunofixation. One thing that I've learned about protein gaps is that there's very poor evidence. I feel like oftentimes we see protein gaps in inpatients, and there's very poor evidence for like if you have a protein gap of greater than 4, send the things. And I feel like it's done all the time. And there was this great paper, I think in JAMA in like the early 2000s, that talked about how that's really not a cost-effective thing. And I think the diagnostic yield is like 0.8% of the time you actually like are revealing some type of underlying plasma cell dyscrasia. But I agree with you, for a patient who's like undifferentiated, coming in with an inflammatory syndrome, has an unexplained cell line down, definitely going to send the workup. This would be like yield that I'm interested in. But I thought you brilliantly talked about kind of not anchoring on the fact that like not all masses are cancer. And I think we should still be thinking broadly, just like you mentioned, thinking about things like infection. And I don't know if there's like any type of like other autoimmune diseases that can kind of present with like something like mass-like. We certainly get the flavor of like localized lymphadenopathy, but I agree with you. I'm interested in malignancy, still interested in infection as well. When I was hearing this CT read, I was actually laughing because Smitha presented a New England Journal CPS case to us last spring, almost a year ago. And it was a case called the terminal event. And I wish I had it in front of me because it actually has a really good differential for like, I think it was this patient just had like ileitis, but I bet you that we could extrapolate much of the differential from like inflammation of the terminal ileum to like an ileal mass. And so Smitha, I don't know if that's something you want to pull up and go through because it was awesome. It was a great presentation. And we presented it to one of the ID faculty at our institution who some of the, I think, the final diagnosis ended up being Crohn's, but we thought for a long time it was going to be TB. So for a patient with latent TB, I'd certainly would be interested in that. But I agree with you. I think getting tissue is going to be the issue here. How we go about getting it, I don't know. I don't know if like endoscopically puncturing through a lumen is the best idea, but I wonder if any of those lymph nodes would be amenable to biopsy. The one thing that I'll say though is that because I'm still worried about this possibly being a lymphoma, I do wonder about like trying to excise an entire lymph node itself. And so I think I'd be talking to interventional radiology and maybe GI to consider kind of how can we best go about sampling this tissue. I don't think, similar to you, I don't have a differential for kind of an ileal mass. So I thought you did a brilliant job of like using what you know about the case to like try to figure out what could be going on here. And this is why we are, presenting this case. It's to learn a little bit more about this. And the only last thing I was going to say is I was trying to figure out if the vascular distribution could explain, like if this clot in the superior mesenteric vein could explain the splenomegaly. I can't remember, however, and I don't know if some person wants to pull up like a vascular anatomy to figure out if the splenic vein empties into the SMV. I think it might. And so I wonder if that could explain the splenomegaly itself. Those are my thoughts. Really interested actually to hear if Sarah and Smitha have anything to add. And I can't wait to hear what the final DX is.
I have nothing to add to that brilliant discussion, both of you.
Yeah, that was awesome to listen to. The thing that I've been thinking about still is trying to tie back, like think about where we started with this case, and we started with the chronic anemia and the acute inflammatory syndrome. And now I think we have a good explanation for the acute inflammation. I'm still trying to, in my mind, figure out whether that chronic anemia is helpful or just kind of background noise. But yeah, I loved listening to the discussion. I agree. I don't have a great differential for exophytic masses in the ileum either.
right.
Jordan, we turn it over to you.
Well, after talking to both radiology and GI wanted to try a colonoscopy with balloon to see if they could actually reach the distal ileum to get a biopsy. They were able to biopsy the lesion, and the final anatomic diagnosis came back as a poorly differentiated neoplasm, most consistent with a malignant gastrointestinal neuroectodermal tumor, also known as MGNET, which is, I can go into a little bit about MGNET because it's a very rare neoplasm involving the small intestine of middle-aged adults. And it is most often in the small intestine, but can actually be in any part of the GI tract. It's really only reported in case reports. There's been less than 50 cases published in the literature. The largest case report had 19 patients, where the mean age was around 43, and most commonly in the small intestine, but it is a very rare type of small intestine tumor, which is, I would not expect anyone to actually guess this, because these are the types of cases where you need tissue biopsy to actually understand what type of tumor this is. So I will leave it at that for now.
Wow. Thank you so much for that expertly presented case, Jordan, and really sad for this particular patient. And hopefully he was able to get access to treatment. But I would love to hear any reflections, Sarah, Ashwini, Anna, that you all have on this case.
That was an awesome case, Jordan. I really enjoyed going through it. I think we got to talk a lot of different things, and it's not a diagnosis I've heard of before. So thank you for teaching us a little bit about it. And I was also curious whether you knew whether his HIV status was at all related to this diagnosis, or if those are just two kind of independent events.
In the literature, there is no association at this moment with HIV and this type of cancer.
And I agree. Thank you so much for this case. I really feel like we got to just talk about a lot of different things, and a lot of things that we may not always think about. You know, iron deficiency anemia is common, but certainly the, ileal mass was really, really helpful to talk about, as well as all the data that we got along the way. I'm curious whether the iron deficiency anemia is actually potentially related to this neoplasm. Is it something, I don't know if you know if it's been seen in the case reports, or if that's still something that's just kind of his chronic background medical problem.
So when they did the colonoscopy, they saw the mass that was intraluminal, and it was easily friable. So the GI doctors thought that that was likely the explanation for his iron deficiency anemia. And then a little bit about small bowel masses, malignant small bowel masses. It's actually much more common to have metastatic lesions to the small bowel versus a primary small bowel malignancy. And the types of metastatic tumors that can go to the small bowel include extraluminal spread, like peritoneal carcinomatosis, which can happen in ovarian, colon, and gastric cancer, or hematogenous spread, which can happen actually in a variety of cancers like melanoma, lung, breast, cervical sarcoma, and colon cancer. But the primary small bowel malignancies that are much more common than this, and this being a very rare entity, only 3% of malignancies are small bowel malignancies. You can think of sort of anatomically, if it's a duodenal primary small bowel malignancy, you think of adenocarcinoma more commonly, and in the ileum, more commonly, you think of a neuroendocrine tumor, and then can be in anywhere in the entire small bowel. Most commonly is sarcoma and lymphoma. So those 4 small bowel malignancies are the most common primary small bowel malignancies.
Thank you for those teaching points, Jordan. This was an awesome case, and I just wanted to highlight that I think recognize, like, you mentioned how uncommon this diagnosis is, but I think that you did such a fantastic job of recognizing that this case had like a ton of teaching points, even though like this is a totally new entity to us. Like along the way, we got to talk about the differential for iron deficiency anemia, what is physiologically happening. Then we got to talk about like the patient having well-controlled HIV and latent TB and how that expanded our spotlight. And then you know, we went through and we talked about splenomegaly and this, like what could be our differential for an ileal mass. And I think the fact that you recognized how rich the discussion would be along the way, and I can imagine it was really interesting to kind of go through the diagnostic process yourself and take care of this patient. So thank you for sharing that. This case with us, and I echo Smith's sentiments in that I hope this patient has access to treatment and does okay. I think with that, since we only have a couple minutes left, we could maybe turn it over to Sukriti, unless there's anything else, Smitha, Sarah, Ashwini, that you wanted to mention.
No, I just wanted to say thank you all again for joining us. And, you know, even though the diagnosis itself was new to us, I think like your sort of authentic clinical reasoning led us to getting that biopsy and figuring out the answer. So thank you. Love how I waxed poetic on splenomegaly for like 10 minutes.
That was an amazing discussion and a great case. Just taking everyone through some of the main things that we discussed today, we began by investigating the symptoms. And right off the bat, Sarah taught us how to make sense of the enormous data that we were given. And she did this in a stepwise approach. So essentially what she did was to identify the main components of the current syndrome and then track them as we went along the case. And the next was to analyze the foreground in the context of the background. So we essentially asked three questions. Did the chronic disease lower the threshold for the acute presentation? Was the acute presentation a part of the natural course of the chronic disease? Or was there an additional pathology altering the course of the chronic disease? Or was the acute presentation and the chronic disease unrelated? And then we sort of did a neurological dissection of the iron deficiency anemia, thinking about time course and localization. So time course helped us to divide IDA into acute versus chronic, thinking about blood loss and hemolysis when faced with acute IDA, and a production problem or a slow bleed when thinking about a chronic IDA. And we also learned from Anna that iron deficiency anemia localizes to the duodenum. And in this case, since this patient also complained of the right upper quadrant epigastric pain, this was something to think about as a potential focus of his syndrome. The next thing that we did was use the past medical history and the physical exam to collect clues and layer this on to the initial history that we were provided with. And what his past medical history of HIV did was to expand the spotlight of infections and malignancies to consider. So thinking about things like lymphoma and Kaposi sarcoma being less likely in this patient given that his HIV was well controlled. And we also learned that the treatment for latent TB is only 60% effective. And given this patient's clinical syndrome, the GI tract is the third most common site for extrapulmonary TB. So TB really rose on our differential. And the physical exam essentially helped us to find a focus for his inflammatory syndrome. So really honing on what is wrong with his gastrointestinal system. And the next thing, and specifically, this helped us later in thinking about splenomegaly. But before that, we had this amazing discussion of the anemia and thinking about iron deficiency anemia. So we learned that ferritin is the first sign sign of iron deficiency anemia, and a ferritin of less than 15% has a very high likelihood ratio. But in an inflamed patient, the ferritin may be spuriously elevated. So this could be a potential pitfall when evaluating a patient with iron deficiency anemia in the context of inflammation. The other thing that we discussed was splenomegaly, and Smita talked about the three buckets in which we think about splenomegaly: water, cells, and molecules. Water is most likely portal hypertension, but with the normal LFTs and the absence of any signs of volume overload, this was less likely. Cells can be divided into WBCs and RBCs. And then again, WBCs has a broad differential of autoimmune, cancer, granuloma, and infections. And molecules are most likely to be an amyloid deposition. Something that we've learned from previous VMRs is that solid tumors are allergic to the spleen. An exception of this is melanoma. So at this point in our case, we were really thinking about a malignancy and an infection. And again, the protein gap helped us to think about this as whether this was a polyclonal versus a monoclonal protein gap, a polyclonal being more common in HIV or an infection, and a monoclonal being more common in a myeloproliferative disorder. And finally, we got our pivot in the form of this ileal mass with the SMV thrombus, and that we use this to frame our hypothesis, being very broad and thinking about malignancy and infection. And I think one of our biggest takeaways was just developing the illness script for an ileal mass. So think about metastatic being more common than primary, and then the different locations helping us to think about the different kind of malignancies that may affect them.
Sukriti, that was amazing. Thank you so much for distilling down so much learning into this nice little section. I hope everyone goes back to read it later on when it's posted on the website. With that, we will close out our April WDX VMR. Thank you all so much for joining us. We appreciate your support. We hope that you bring this energy back to your all's home institutions, and we look forward to seeing you for our May WDX, which will be at the end of the month. So stay tuned via Twitter, and we will let you all know when that will be. Have a great day, everyone.